Hey class, I'm Lorenzo Lopez. I did my presentation with Greg Flores, and our focus for the topic was the prevention of the onset of major depressive disorder. Due to some technical difficulties, I was unable to bring the PowerPoint into my presentation today, so I wanted to just kind of go over the roadmap just to make sure we're all on the same page. Uh, Greg kind of took care, or he did take care of the key terms and concepts, statistical evidence of the major depressive disorder, types of prevention, methods, quality assessment, along with analysis. I will be taking you through the results, included studies, incidence ratios, the subgroup analysis, discussions, and our future research. Jumping right in, let me find it. Jumping right into the results, we saw that our authors used or found 235 articles, but because they didn't meet the criteria of what Greg talked about along with the DSM-4, they had to exclude 203 articles, leaving 32 viable studies with 34 comparisons across those studies to work with, which is pretty interesting because they were able to break it down to what they exactly wanted and what they were wanting to find and use to compose their study, which was pretty interesting, just being able to focus in on that. Looking at the characteristics of included studies, 32 cases were used, and the participant total of those 32 cases were 6,214. That's between the prevention and control groups. In each of those studies, they found 21 studies aiming for the prevention of major depressive disorder. 9 went for postpartum disorder, which can be seen as PMDD. 4 studies focused on those who had experienced depression for the first time, but most out of all those studies, most of them were seen being studied on adolescents and students. And what was interesting to me was the therapy route for the interventions. 15 of those were based on cognitive behavioral therapy and other problem solving psychological therapies, along with interpersonal therapies. And it wasn't just those that they focused on. You could also see in the article that they focused on 8 focused on adults in general, 8 focused on those with a history of depression but not have been diagnosed as depressive disorder, 3 on new mothers, and 6 on pregnant women. Most of these studies had used 12 intervention sessions just being the amount of times they took to take those therapies or take the route of what they wanted to do for the prevention, while others used 2 to 10 sessions. So with that, 11 studies were conducted in Europe, 14 were here in the US, and 9 were elsewhere. And they lasted anywhere from 2 to 60 months. And the interesting thing to me was none of those studies were able to meet the full criteria, but just enough, exactly 1 to 3 times, but none being the full for what they wanted to see. Looking forward to the overall incidence ratios, all calculations were made between the 34 comparisons of the interventions. The fixed effects model had an 82% incidence, the random effects had a 79% incidence, and the heterogeneity at 24%, which if you went through the article, you would see that they made it a point to say how extremely low that was. And what was interesting also to me was the examined incident rate follow-up periods. They decided to take it upon themselves to, they had studies that were so spread out and so wide range. They wanted to do their own follow-up periods to make sure they got exactly what the exact data that they were looking for. They did, so they decided to do them at 5 months, 6 months, 7 to 12 months, and 13 months. And it was pretty cool just because the difference between the fixed effect and randomized were so small that they just decided to use the random effect model and report what they found from that in their study, although they were able to find both random and fixed effect. For the subgroup analysis, They wanted to examine whether the incidence rates differed in any way between the prevention, the intervention, so like the types like the cognitive behavioral, interpersonal, and the others like the psychological problem solving, and age group. They decided to break it down between adolescents, adults, and the elderly. What was interesting was there was no difference between subgroups and incidence rates, and you would at least think between age group for at least adolescents and elderly, or adults and elderly, however you want to look at it, you would think that you would find at least enough to be able to report on. They also looked at the examined numbers to treat, CBT being 71, IPT being 7, and IPT is the interpersonal therapy, and other like those problem solving therapies and the other psychological, they equaled out to 12. They found, like I said, they found no difference, but what they did find was, according to their meta-analysis, that IPT was more effective than the other types of therapies taken. And looking into the discussion, they wanted to find whether the preventative interventions are more effective in reducing the major depressive disorder. Luckily, they were able to find that with the use of the intervention models or intervention methods, they were able to lower the incidence rate by 21%, which is pretty decent. That's a pretty big decrease on how they wanted and what they wanted to find. And although the number of studies were low, they saw that interpersonal therapies did have a higher prophylactic effect than cognitive behavioral therapies. But again, they say that with caution, just due to the fact that they only had 5 studies using interpersonal therapies. Lastly, indicated prevention was not more effective than selective prevention, and they say that just based off of the incidence rate of indicated prevention being 74%, and the selective prevention being 81%. Due to this, looking forward, they wanted to find new ways, new studies or new strategies to find to help prevent major depressive disorder. So for looking to further research, 2 types of strategies that you could use looking forward would be population and individual strategy. Population strategy is focusing on a whole population regardless of risk status. So what does that really mean? Taking a group of people who, have had this, who have had, depressive states, or whether or not it's a diagnosis, or whether or not it's, as little as feeling down for a whole week, but that could cause problems that just depending on how you take towards that situation. And so you just want to be careful, just because you have such a big group of people with different risks and different statuses. You just want to be sure to, attack it the way you need to. For individual strategy, that just targets individuals of high risk. That looks, looking at, individuals who probably have been diagnosed as depressive and have been struggling with major depressive disorder for a very long time in their lives, and it's affecting, the way they live, the way that they live, So those ways, using those therapies like interpersonal, cognitive, behavioral, just trying to change the way, just to kind of lighten the load of the disease, because major depressive is very crippling. But if you use them right, intervention does not fully by any means take away the disorder. The disorder will always be there. It is found useful, though, to reduce the burden of the prevalent and the mind-crippling condition called major depressive disorder. Lastly, if you click through into the last slide, you'll see our work cited, which is the Preventing the Onset of Major Depressive Disorder, a meta-analytical review of the psychological interventions. Thank you. I hope you enjoyed this presentation. Again, I apologize for not being able to put the presentation into this video, but I hope that it worked out well for all of you guys. Hope to hear from you on how you liked it. Later.